I'd like to welcome everybody to this webinar on therapeutic temperature and also welcome our esteemed hosts. Just a few explanations for today. We'll be doing this was two short talks with a short question and answer period in between. And for the questions and answers, you have two options. One is you can type them in the chat or you can save them till later. And we'll open up the floor later for the question and answer. I'm Nicholas Verhulst. I'm the Clinical Development Director for EMEA LATAM for Zoll Medical, and welcome. Like I said before, we have two hosts or two speakers with us today. The first one will be Professor Andreas Schaefer from Hanover University. Professor Schaefer is the Deputy Director of Cardiology at the Hanover School of Medicine and actively works at the Hanover University Hospital, as well as the head of cardiac intensive care. He is an intensivist, interventional cardiologist and intensivist with over 262 publications. His main interest is in PCIs, ECPR, mechanical circulatory support, cardiogenic shock, clinical cardiology, and of course, all things related to resuscitation, improving outcomes for patients. The second speaker we have from Yale is Dr. Rachel Beekman. Dr. Rachel Beekman is a neurointensivist with expertise in identification and management of hypoxic ischemic brain injury. The central goal of her research is in the early classification of brain injury severity, identification of secondary brain injury risk profiling, and using multimodal monitoring, individual brain-centered resuscitation to minimize secondary brain injury and neuroprognostication. She's also involved in the ICE-CAP study in the US, and both of them will be speaking to us today about their experiences in therapeutic hypothermia. So with no further, I'll pass it over to you, Professor Schaefer.
Yeah, Nicholas, thank you very much for the kind introduction. And I will start with the presentation, actually more or less focusing on the limitations in current evidence, where there are gaps and where there are opinions that might not be applying to all the patients. Now, all my talks on this topic are dedicated to a species that is endangered by inadequate temperature management and temperature control. I will come to that back in the end of my talk. Anyway, now let's focus on our patients after resuscitation. Now, the setting that we work in is one of a cardiac intensive care unit. And if we want to treat these patients rapidly, seriously, and adequately, we need to take care of these patients from the very beginning they enter the hospital. So the patients will enter the hospital in the emergency room, and the intensivists from cardiology and the interventional cardiologists are already on board when the patient is received by the cardiac arrest response team in the emergency room. Then there is a clear strategy of patients with new development of cardiogenic shock, shockable rhythms, ST-SAGWIT elevations going primarily to the cath lab, thus with non-shockable rhythms or without ST-SAGWIT elevations primarily going through CT. So once going through cath lab, go through CT afterwards prior to admission to the cardiology intensive care unit where the cardiac arrest center is harbored. Now, this kind of direct stream up pathway ensures that the people that care for the patients in the end are involved from the very beginning. They get all the pre-hospital notes from the emergency physician and the paramedics immediately, and there is no loss of knowledge of the pre-hospital situation anywhere. There's a clear standardized approach to post-arrest and cardiogenic shock for these teams. And when we do treat them on the right-hand side, you can see not all kind of shock or resuscitated patients are equal. It makes absolutely a difference whether the patient arrives in the hospital during resuscitation as an ECPR case or going on ECMO. Even you have the best setup, you will have a very high mortality. Or whether the patient is resuscitated, has ROSC, but is in cardiogenic shock requiring mechanical circulatory support, still some substantial mortality. Or the patient is cardiac arrest without shock, it's even better in the overall perspective. And if we go down to the patients that fit the inclusion criteria of the TTM1 trial, you can see that in modern intensive care, you will end up with about only 20% mortality of that patients, much, much lower than what has been reported in the trials. And on the long term, with a substantial number of these patients, actually, of the survivors having a good neurological outcome. Now, we have to do a couple of things to get the patients there. And one of the things is we have a very stringent intensive care, and this is just for those who are not working with an intensive care, how the area of such a resuscitated patient may look like. The patient is connected to many monitoring units, is ventilated, eventually on a circulatory support system, on an active cooling device. There's a defibrillator somewhere. Some of the patients have renal replacement therapy, and there's a lot of infusion pumps going on. So what we want is we want to continue the therapy for the first 72 hours. We do not want to interrupt it, specifically not the hypothermia, and we do not want to move the patient unnecessarily. And that is why we have kind of implemented an algorithm where we do all this in the beginning and to implement hypothermia very quickly and really in a dedicated way. Now, if we talk about something, and I had to address the lack of evidence, so I just want to give you some evidence. With whatever intervention we do in modern medicine, we like to go into animal models before. So there is a nice review by a German-Austrian group that had looked into many animal experiments, large animals, small animal models of cardiac arrest, hypothermia versus normothermia, and always hypothermia improved neurological outcome. Within a range of 32 to 36 degrees, each degree of lower temperature was associated with better functional outcome, and faster cooling and reaching the target temperature within a dedicated window actually improves outcome. So in animal models, there's absolutely no evidence that normothermia is equivalent to hypothermia. There's no evidence that fever prevention is equivalent to hypothermia. If we go to the human data, the first randomized controlled trials, and that was a big step forward, leading to the implementation of hypothermia in guidelines. The review meta-analysis is already 10 years old. The data is another 10 years older. But nevertheless, these were the two, I think, most important trials in this area. The one from Austria and the other from Australia, published back-to-back in the New England Journal in 2002. And they found that there was a 25% reduction of mortality by applied hypothermia to arrest patients. And there was a 27% lower likelihood of poor neurological outcome when you do it. So in patients for cardiac arrest, there is a clear demonstration that hypothermia has a positive effect. Now, if you look at the trial size, especially of the Australian trial, they're low numbers. And we were to do these trials differently if we do them this year, this time, this decade. But at that time, this was the way trials were done. And these were the positive trials showing that this intervention on top of standard therapy provided benefit, reduced mortality. And we should not say these trials are hypothesis generating. We do not look on them anymore. It is kind of a cancel culture that we see in some of our social environments, and we shouldn't apply that to science. There is science, and it shows there's a benefit. So there were some questions, and one was raised in the HACA trial because the control group wasn't normothermic, so it was slightly in a fever area. And we know that fever actually increases the likelihood of poor neurological outcome. So it could have been a fever effect putting the control group in an unfortunate way, or it could be the hypothermia putting the interventional group in a fortunate. Now, when we look at the other two trials that came up, the TTM1 and TTM2 trials, they try to compare controlled normothermia to hypothermia or fever prevention. Actually, the trial looking at fever prevention also failed somehow in a substantial number of patients to prevent fever. Now, these trials were done, and they had a very high variability in the maintenance of hypothermia, which wasn't as much in the earlier HACA trial. Now, what was the point about these two new trials in comparison to the older HACA trial that substantially showed a benefit reducing mortality by hypothermia? Both TTM1 and TTM2 didn't. And the question was raised, why didn't they show a benefit? And the answer was because intensive care has improved. But if we look at the disease severity in the trials, TTM1 was the less severest compromised patients, followed by TTM2, and HACA actually having the most compromised patients. So why was the oldest trial with the most compromised patients having the lowest mortality? I think this cannot be explained by improved intensive care. And we have to be very careful about the interpretation of these similar curves that go very rapidly with mortality in the first days. Can we do better than have a varying response to hypothermia or cooling? Yes, we can do very better. This is a trial from Denmark, actually looking at patients very similar to the TTM1 trial. The inclusion criteria were more or less identical. And what you can see by using more intravascular temperature management, almost 2/3 of cases, you get the patients to the adequate target temperature within 1 to 2.5 hours. So this is very important. Get to the target very, very quickly. Why do I show this data? For two reasons. One, with all that the extended hypothermia group 48 hours was actually doing better than the 24 hours. The effect wasn't statistically significant, but that was based on a wrong assumption of high mortality, even higher than in the HACA trial, which was actually already proven to be wrong. So the power calculation was wrong, and well, because the power calculation was wrong, it wasn't significant. The predicted effect, they assumed 23% risk reduction, they achieved 21%, was exactly on the mark. And the second point I want to point out this trial is the patients had the same inclusion criteria like in TTM1, but the mortality was much lower in both groups. So there was a difference between the two trials, and we come back to that. If you look at the implementation of hypothermia, if you write hypothermia in the title of your trial, in the title of the publication, you should actually induce hypothermia. That was done in the old HACA trial. Surface cooling took some time, but the patients were severely compromised, and even achieving hypothermia at about 8 hours after ROSC was sufficient to show a benefit. The Australian group was much more progressive cooling in the ambulance, so they started very early after ROSC. They achieved within 3 hours from ROSC the target temperature. And as I may admit, Melbourne is an environment where it's very hard to cool patients adequately outside the hospital. Now, the TTM1 and TTM2 trials, which were called the landmark trials, actually now that's a standard in guidelines saying hypothermia might not be necessary. They failed to do what they're raised to do. Actually, TTM1, it took more than 3 hours on average from ROSC to randomization, and it took more than 9.5 hours to get the patients on target temperature. That is far beyond the place of 6 hours where we want the patients cool. Even TTM2, the next large trial, missed out. More than 50% of the patients did not make it to 33 degrees within 6 hours. It is possible, demonstrated in different other trials. The latter three are pilot trials showing that there's a short time to get to target temperature if you use intravascular cooling. We do apply in Hanover, in the Hanover Cooling Registry, only intravascular cooling, and this is real life. You see, this is not to randomizations, it's to from ROSC to the start of cooling, and the red phase includes the ER, includes the cath lab, includes the CT scan. And then you start with an intravascular cooling. The catheter is placed before the patient reaches the intensive care unit, so one of the nurses can just connect the device, and you get a quick time to 33 degrees. So if you stratify your approach to the patient, you can make it very easily. And there are several things to do. Patients come in cool already. Don't actively rewarm the patient, cover a patient with a thin blanket, have strict and protocols, use the first line, central line as an IVTM line, and start active cooling very, very rapidly. Because we have learned after this first TTM trial and this is something that raises the question about the lack of evidence in the trial. Many nations have shifted on a national scope from the hypothermia to normothermia after TTM1 was published, so from 33 to 36 degrees. And this is the group from Melbourne, actually, who did one of the first trials for hypothermia. Then they participated in TTM1 and they compared the patients before TTM1 publication and after TTM1 publication. And you see, they go back to 36 degrees, and you see here, hospital survival, less, good neurological outcome, much less. And that raised questions. This was one unit in Australia. These were all the units, intensive care units from Australia and New Zealand. Prior to TTM, declining temperature in resuscitated patients, declining mortality. Publication of the TTM trial, increase of the temperature, increase of mortality. 235 ICUs from the United Kingdom. Prior to TTM, declining temperature. After publication of TTM trial, increasing temperature in patients treated after out-of-hospital cardiac arrest. Upon publication of the trial, a rise in the hospital mortality, and that is actually on a much higher scale in patients that are non-shock or non-ECPR, reaching almost 70%. Now, what is the philosophy behind it? We have different patients. Not all resuscitated patients are equal. We have patients that have out-of-hospital cardiac arrest, that get early CPR, most of them, many of them in trials, they have witnessed arrest, they have bystander CPR, a higher level of shockable rhythms, public arrests, whatever. They get CPR, they get quick ROSC, they have reperfusions, they have a minor reperfusion injury, minor ischemic injury. These patients will do well. However, this was more or less the focus of the TTM trials. So how can you improve the outcome of patients that are doing well? On the other side, you have patients that do not have bystander CPR, that have unwitnessed arrests. Many of them have non-shockable rhythms, non-ischemic problems. They have a long ischemic time for the brain, a longer reperfusion injury. These patients are going to do bad. And they have such a big insult prior to arrival in the hospital that it actually might not matter what we are doing with these patients. And then there are the patients, a large proportion that we see in real life, that have a reasonable time to get layperson resuscitation, that get telephone-assisted CPR, that have a first responder coming around, early defibrillation things. This is a typical 25-minute to ROSC patient with some ischemic injury, some reperfusion injury. And this is where reperfusion injury and post-resuscitation care matters. And this is actually a high proportion of our real-life patients. And we have to be careful to transfer data that is gained in this area to the lower twos, which might not apply to. And this is exactly what our colleagues from Japan found out when they looked at neurological outcome after switching from hypothermia to normothermia. There are some patients that have a low impact. They are doing well. There are some patients with a higher or stronger impact. They are doing bad. And there is the intermediate area. And these patients, they do much better if they have the 33 to 34 decrease compared to normothermia with regard to survival and with regard to good neurological outcome. So there is no data showing that normothermia is equivalent to hypothermia in real life. If you look on the Mosen trial meta-analysis Cochrane review base, you can look at comparisons, witnessed arrest, non-witnessed arrest. So the non-witnessed arrest patients usually have the stronger impact. They have the higher benefit by cooling, but although the patient with witnessed arrest, they also have a good benefit. If we look at some published evidence, we have the old trials with improvement in mortality, then we have the 2 TTM trials, and then we have several other trials, sometimes single-arm pilot trials, the comparisons that I showed with 24 to 48 hours, or our registry data focusing on patients matching the TTM inclusion criteria. But the difference is that all of us were much quicker in reaching target temperature than TTM, and strict protocols, intravascular cooling, and the mortality is much lower. So we have to question the validity of these TTM trials. We can do this on a national basis. We look at national registries, the German resuscitation registry, looking at German and Austrian data, 34,000 patients. Thus, with mild therapeutic hypothermia had a better outcome, hospital discharge, or good neurological outcome compared to thus without this treatment, and on a national statistical office exploration in Germany, we could look at STEMI patients, 133,000 that had been resuscitated, comparing them with standard therapy and hypothermia, and then looking at those who were admitted to ICU, being ventilated. There's a clear statistically significant signal in favor of hypothermia on this broader real-life observations. And if we go back to the Cochrane review, we see actually that the majority of trials was in favor of cooling. In each aspect, cooling versus no with fever control or cooling versus 36 degrees, there's only one outlier, and the one outlier is a TTM1 and the TTM2 trial. It's not the other trials that are outliers. It's the TTM trials that change the guidelines who is falling out of the picture. But these trials were thus with the highest number of patients and therefore driving the interpretation. But if we look at the overall picture, there is a good indication in favor of cooling. Because we have to challenge these trials for some other reasons. In the protocol for TTM2, in that the local protocol should be developed to ensure that it is feasible to reach the targeted temperature within 90 minutes or shorter in the majority of participants. First of all, it says local protocols should be developed. There was no protocol given, provided how an investigator could actually do this. Second, if we should have the target temperature of 33 degrees within 90 minutes in the majority of patients, means that the median has to reach the 33 degrees at about 1.5 hours. The median reached the 33 degrees at 5 hours after randomization. And that clearly shows that this trial didn't really investigate hypothermia because they were not able to induce it. And it is an intention to treat analysis. And the protocol says that per protocol analysis may be considered if important deviation from the protocol compromise the validity of the ITT analysis. And I think the violation from the protocol is so extreme that the validity of the analysis is actually really compromised. So the PIs did not provide a protocol to achieve the demands, and therefore the trial didn't even investigate what they actually claimed to do. High mortality very early in the trials, the next limitation. You see the TTM1 trial has steep mortality, much stronger than in the old HACA trial. Why was the newer trial so bad in the early days? It was bad in the early days because it changed something in the protocol. They did a kind of a standardized intervention, which was 72 hours after starting the cooling. They introduced the neurological prognostication connected with the withdrawal of life-sustaining therapies. Now, if we look at guidelines, they are kind of vague, even now, saying that we need to apply 5 different techniques and 3 have to be highly pathological to make very poor prognosis. But if we look at the modalities, how they were applied in the TTM2 trial, it gives us a picture that almost every second patient got an EEG, 2/3 of the patients got cranial imaging, less than 20% got evoked potentials, and just half of them got NSE measurement, which was considered pathological if it was higher than locally associated with poor outcome, but the cutoff was never really shown. And we have different cutoffs going through the literature. In some of the literature, it said an NSE at day 3 of above 30 micrograms per liter is pathological. No, if you are between 30 and 60, 1/3 of your patients have a good outcome. Even if you're above 60, which is quoted in the European guidelines at the moment, you still 7% of your patients have a good neurological outcome. So therefore, some people in the literature and the German neurological guidelines actually demand a cutoff of 90 or 100 for a negative prognostic impact. At the end, I just want to give you one case to illustrate what we are doing. A 38-year-old patient witnessed arrest, initially without basic life support, but rapidly introduced ventricular fibrillation, ongoing CPR on a Lucas device. He was admitted for eCPR, had ROSC after 47 minutes, 6 minutes prior to the ER, was intubated, ventilated, there's a hypotension going on ECMO, and we actually like to know whether these patients have a chance or not. So there are several predictive scores around for the ER, and I would never use them in a clinical way. We use them for research, and in this case, they say about 90 to 95% probability of poor prognosis. But would you stop treatment at this moment based on such a score? Would you stop treatment at day 3 once your NSE goes above 60? Would you stop because of a myoclonic state? Would you stop because of signs of beginning anoxic brain damage? Actually, this is an accumulation of parameters that in the TTM trials would have led to a withdrawal of life support. However, we did not withdraw life support. We went on, and this is our patient at day 20. And I think this is the reason why we should not give too much on trials that were made with a completely different patient population. So you have heard in the last 20 minutes that I'm a believer in cooling, in hypothermia after cardiac arrest, but I'm maybe not an expert. So I tried to find an expert in the town who could answer the question, how cool is cool? Now, this is the expert I found, and his advice was, global warming kills populations, local warming kills individuals. And that's, quoting this, I thank you very much for your attention. I'm happy to take any questions.
Excellent. Thank you very much, Professor Schaefer. We'll just, if anybody has any questions, we have a few moments to